Welcome to the Spinning Babies Childbirth Preparation class for parents. We're going to talk today about physiological birth and comfort in pregnancy. Physiological birth is a birth as nature intended, with the mother's own powers starting the labor on its own and fulfilling the labor on its own spontaneously. All right, let's go through the class together and introduce ourselves, saying which baby this is and what brings you to the class.
My name is Joanne Youngsma. This is my third baby, and I'm here partly to find a little more comfort during pregnancy.
And I'm Amber, and I'm her doula.
My name is Lauren, and this is my husband, Ryan. This is our first baby, and we're here because she's persistently breech.
Hi, my name is Sarah, and this is Brian, and this is my first and Brian's third. And we're here because I want to get as much knowledge as I can about how my baby and I can work together when we're birthing, and how my husband can be a support to that.
My name is Laura, and this is
Carlos,
my boyfriend. And it's our first kid, and we're here to learn more about pregnancy.
My name's Michelle, and this is my husband Steve, and we're just here to gain more knowledge and just to make it easier during the birthing process.
My name's Ayana.
And I am Paul, and we're here to gain more background knowledge about birthing.
Many of you are expecting your first babies or to have a simpler, easier birth. And I think that the premise for that is that fetal positioning matters. A lot of times when we think about the birth that we're going to have, we have intentions and we have an ideal of what we're expecting to have happen. And for many of us, for many women giving birth, those ideals can come true with support and preparation. In fact, if we think about all women birthing, and we have this magic bell curve here, most of the time there's some work involved, which is why we call it labor and not vacation. That some women are going to have an easy time, and some women are going to need some more help. Maybe they need some help of their doula, their midwife or doctor, and even a few women are going to need to have a cesarean, even though they plan to have a natural physiological birth. And many women can have a physiological birth simply because we're designed for birth. Our birthing bodies have the hormones and the structures to open up and have our baby. But our society isn't really designed to support birth. We sit a lot today, we drive a lot. We have, here I am leaning on my right foot. We favor one side of the body, how we carry things, how we cross our legs. And this makes some changes in our bodies that our babies need to navigate. So spinning babies is about the baby's role in birth. As a doula for over 30 years and a midwife for over 20 years, of course, I'm very interested in helping women have a more comfortable pregnancy and a more comfortable birth. I would help women that would have the best intentions and good preparations, and sometimes it wasn't enough. The labor might have gone a couple of days. She might have had some back labor, which is feeling most of the contractions in the back instead of where she expects to find it. Or there'd be just things that she didn't expect, which is hard on the morale. And as I watched that, I found that the baby's position mattered, that the angle of the baby's head in the pelvis really played a strong role in the process and the progress of the birth. And as I was on a quest to learn more about that, I found the book of midwife Jean Sutton and childbirth educator Pauline Scott from New Zealand, Optimal Fetal Positioning. And Jean sets it out on how fetal positioning influences the birth. This helped many more of the women that I was helping as a doula and midwife move from a more difficult birth, and sometimes just before a cesarean, using these techniques over to the easier side of labor. But it still wasn't helping every woman. So I had this question, why not? This was helping more women, but not every woman. And then I found the work of Dr. Carol Phillips, who brought in dynamic body balancing, how the mother's body has tension or looseness, and if we can balance that out, bring it into alignment, and help it be more flexible, mobile, and symmetrical in the tensions and the loosenesses of the muscles, ligaments, and joints, the baby can navigate the location of the womb and the pelvis much better. You know, so much attention is on the mother's dilation. How far along is she dilated? We don't remember that 50% of the work is done by the baby. So the way the baby is coming into the pelvis helps the labor. It's mom's job to dilate, but it's baby's job to rotate. So what we're going to talk about today is how can we help the baby? Let's make more room for the baby so the baby has an easier time. As we're talking about birthing anatomy, we often talk about the female pelvis, the tunnel for the baby to travel through. The pelvis has 4 joints, the sacroiliac joints in the back, the symphysis pubis in the front, and the coccyx that opens like a door as the baby comes down through the pelvis. The sacrum also moves, and actually, shortly before birth, moves outward, opening the pelvis 2 more centimeters. The female pelvis has 3 levels. The level of the brim, the true inlet of the pelvis, where the baby engages at the end of pregnancy to snuggle down into the pelvis. The pelvis has a mid-pelvis, the halfway point, which is the narrow part of the hourglass of the pelvis. The ischial spines marks the halfway point. And the pelvis has an outlet. The sits bones marks the end of the tunnel. Actually, our skin extends a few more centimeters lower than our pelvis. So even when the baby's head is coming through the sits bones, we don't quite see the baby yet, even when it's outside of the pelvis, until the perineum blossoms and opens. You can find your sits bones right now. It's right where if you have a child sitting on your legs and sits on your thigh and you feel the little bony butt of the little child after a while, that's our sits bones. If you could find your landmarks, it's good to know where your sits bones are. It's good to know where your sacrum is. If you can curl your hand and find your sacrum, it's a triangular base of the whole spine. And the symphysis pubis in front, the pubic bone, is where these 2 bones actually come together and join by cartilage. Sometimes at the end of pregnancy that gets a little achy because it gets more mobile. Some of our stabilizing and balancing exercises will protect your symphysis pubis by strengthening the muscles to the pelvis. So that's the bony pelvis, but the secret is the baby doesn't just navigate the bones of the pelvis, but the baby needs to navigate what's called soft tissues of our body. Sometimes they're not too soft. Here's a model of the soft tissues of the pelvis. We have the pink uterus as a balloon. We often think of the uterus as something symmetrical and round with even sides inside. But there's other structures that shape the uterus. One is the big broad ligament that holds the uterus somewhat in place and also gives it mobility for movement. The broad ligament attaches inside the sacrum in the back. Signs of a balanced broad ligament are the dynamic motion of the uterus. Signs of a tight broad ligament would be discomfort when the baby kicks, would be a discomfort in the SI joint. We also have the round ligaments. They come up the front. They also are part of the support of the uterus, allowing motion for it to come backwards and forwards. They attach on the inside of the pubic bone and extend down towards the lower part of the pelvis. Signs of a tight round ligament are actually a sharp pain that feels almost like tearing in the mother's side. Not unusually about 18 weeks of pregnancy, a twinge or 2 will be felt that week, or between 15 and 19 weeks of pregnancy. But if that continues, it can really affect how the baby is able to move around in the womb, because a tight round ligament becomes a speed bump that slows the baby's travels. We see this bladder a little bit to the right, which is actually how our bladders are located. They favor the right slightly. We see here the pelvic floor, opened front to back like a buttonhole, helping the baby rotate through the pelvis. It's an opening in a muscular floor that's lifted to support our internal organs. And as we push the baby out, the pelvic floor stretches around the baby's head. We also have ligaments in the back of the pelvis that stabilize the pelvis. We have a sacrotuberous ligament and a coxal spinal ligament that bridge this opening on both sides of the pelvis. It's shown here, one. And if these are tight, the mother might not know it, but it can bring the sacrum into the path of the baby. So we want to make some more room for the baby by helping all these ligaments have dynamic motion. Very often in society, we find women who have tightness in these ligaments due to simple things of posture, sitting and driving, but also to a sports accident, a fender bender, any sudden stop to the body. It could happen in childhood and show up in labor. It could happen in adolescence and show up not only in labor, but in our 50s. So we want to help there be motion and movement. Today we're going to talk about fetal positioning. Here we see babies in two positions. We see the baby in the anterior position facing the mother's back. And here we see the posterior position. The baby's facing the mother's stomach. But most babies start out facing a side. They're either facing the mother's left hip or the mother's right hip. Most of the studies about fetal positioning think that babies change their position at random because these studies haven't looked at the babies that are coming from the right side compared to the babies coming from the left side. And this matters, and let's take a look at why. Here we see the uterus. The shape of the uterus, while pear-shaped in the first-time mother, is not symmetrical. It's not exactly the same on both sides, and this is the normal uterus shape. This is what we expect and hope for. This is the design of the uterus. It's called right obliquity. We've had it since antiquity. That's my little memory clue. We see that on the right, the uterus is steeper. We see on the left, the uterus is more curved. Let's see how this affects the baby. The baby coming down from the mother's left curls into that curve of the left side of the uterus like a hammock. And this helps flexion, and as the baby comes down lower at the end of pregnancy, more and more flexion occurs to set the baby up to fit the pelvis in the most ideal or optimal fetal positioning for the start of labor. You see the baby would kick to the mother's right. The baby starts to turn towards the mother's back late in pregnancy, and so the hands are quiet. The mother doesn't feel those hands back by her spine. She feels the firmness of the baby's back. She needs to differentiate. Am I feeling the firmness of the baby's back, or am I feeling a firm, broad ligament? And take the time to discern which she's feeling. The baby coming from the right fits and matches that right obliquity with a straighter back. And that lifts the baby's head, and as the baby comes down, its potential is to turn towards the front in the posterior position. The mother will feel both of the hands of the baby wiggle once or twice a day when the baby's in this position, because the baby is wiggling its little hands towards its mouth. The feet will kick towards the front and towards the left when the baby is in this right occiput position. And that's why right and left matters as much as facing the front, because the spine pushes the baby's back into extension when the baby's back is to the mother's back. When the baby's back is towards the front, the baby hammocks into this nice curve, and all is quiet and well. And so, how can we know if the baby's in the anterior position or the posterior position? It's pretty simple because of the feeling of the hands in front. If you feel hands on both the right and the left of your navel line, that line that develops in pregnancy, then you're pretty sure that the baby's hands are towards the front. You feel the hands wiggle on the right and the left. They're near the mouth, so we know the baby's facing front. When the baby faces the back, all's quiet in the front. It's not 100% for sure that the baby is this way because the placenta could be there, hiding the baby's fingers, or that tight, broad ligament might be hiding the baby's hands from you feeling them. So as we soften this broad ligament, you'll start to feel your baby's movement. We're also going to talk about the baby's anatomy. Babies' heads are heavier than their bottoms, so that about halfway through pregnancy, babies are gently floating on their side, and then as the weeks go on, and we get to 24 to 28 weeks, we often have a head-down baby. The baby can move on an axis when there's balance in the womb. When there's room in the womb, the baby moves freely. But because the head is heavy and the top of the back is heavy, babies tend to settle in a head-down position. As the uterus has more room, about 36 to 38 weeks as the uterus grows, the baby starts to tuck its chin and settle lower. This becomes important to aim the crown of the head into the pelvis. The baby's head shape determines how the course of labor goes as well, because the dome of the head, the large part of the head, molds best in back where the crown is. And if you'd be an angel, put a halo over your head. Feel your head on all parts of your fingers. You see that roundness. Well, the baby's head there molds as much as it needs to fit the pelvis. But the top of the baby's head doesn't mold very well. It kind of comes up like a little mesa sometimes when the baby aims the top of the head into the pelvis first. So flexion, which means curling up, is much preferable. It's a physiological norm for all mammals with vertebrae, and in our developing babies, flexion is the norm. Let's take a look at the diameters of the head. With flexion, the baby's back is curved and the chin is tucked towards the chest. The crown of the baby's head comes first into the pelvis, and then the diameter of the head is the smallest to fit in the pelvis. The baby's spine is set up so the baby can wiggle and help with the birth. So when the chin is tucked, the head is at the smallest diameter. When the baby comes in with the chin away from the chest, which is called extension, the back is more straight and the chin is lifted, then the whole head comes through the pelvis at once. And the top of the head aims into the pelvis. And then we have a bigger diameter of the head. And so the baby seems bigger. But not only does the baby seem bigger and the head doesn't mold as easily, the baby whose chin is up can't wiggle as easy. The spine isn't set up to help with the birth, so the mother has to do more work for her and the baby, and sometimes it takes a little longer. It really depends on other factors of the mother's body. Flexion is so important. Having the chin tucked to the baby's chest helps the birth so much that we could call this chin tucking babies instead of spinning babies. It's just not as snappy. Well, how can we help the baby have more room so the baby can get to the left? That's where we bring in the body balance. That's where we start to add balance to our body, to the muscles and ligaments. With this knit uterus made by Emmy Corbet, we can see the parts of the uterus. The fundus with the muscles and the blood vessels that fill to contract the uterus and empty and fill and empty to pump the uterus. We see the lower uterine segment that's smooth and soft and gets softer at the end of pregnancy and more round. Room for the baby comes in this area. We see these round ligaments that come from the front. And when the doctor or midwife feels for the baby's head, their fingers often go right by these round ligaments. So if they feel a little twingy, that's a hint that they're a bit tight. They shouldn't feel twingy or uncomfortable when palpating or feeling the baby through your abdomen. In the back, we see two ligaments that attach to the sacrum called the uterosacral ligaments. These play a part in the room for the baby because if one is tight, or two, they'll twist this lower uterine segment, and that reduces room for the baby. Then the cervix has more trouble opening. Here's the cervix, or the door of the uterus, that gets all the attention. But if the baby above the cervix is applying its head to the cervix will open. So I'm not concerned with cervical dilation except as a clue to what the baby's doing on the cervix. Let's take a look again at the lower uterine segment. Here's a water balloon, and the water balloon has a line through it to show you a symmetrical line. Now, if the sacrouterine ligament in the back is in a twist, it makes less room for the baby. And you see now, where's the baby going to put its head? Maybe with this twist, there isn't room for the crown of the baby's head. That dome of the baby's head doesn't fit sometimes, and the forehead fits. If there's a little less room, maybe the forehead doesn't fit and the bottom fits. And if there's a great deal of twist, the baby doesn't fit there at all, and the baby needs to lay sideways. When the baby is coming sideways, it's in a transverse lie, and it cannot fit through the pelvis. The baby in the transverse lie has to be born by cesarean section. If we can take the twist out, we make room for the baby, and the dome of the baby's head, the crown of the baby's head, can come into the pelvis and be in an ideal position to start labor. I want to come back to our bell curve. Let's think now about this being a bell curve of all posterior babies. Some of these posterior babies are going to be born easily still. Maybe they take a half an hour or more, just time for the midwife to get to you. Many of these posterior babies are going to take some time because the mother does more of the work of the labor. Some need some help from the physicians and the midwives, even forceps, vacuum, epidural, or even a cesarean section to be born. So we're very interested in helping the mother with a posterior baby move towards the easier side of her spectrum, or perhaps bring the baby out of the posterior and into the anterior position. We can do this with balance most of the time. If the baby is posterior at the start of labor, the baby's forehead may not allow the baby to get into the pelvis because it's resting on the bone. We need to help the baby tuck the chin and rotate in order to engage in the pelvis. We'll talk about engagement this afternoon with labor phases. Of all posterior babies at the end of labor, if the baby is still posterior at the end of labor, it's about 50-50 whether they can be born vaginally. So it's of our interest to help make room. If the baby starts labor in the posterior position, the first roll of uterine contractions is to rotate the baby over to the left side, tuck the chin, and let the baby engage in the pelvis. We try to add balance so that the baby doesn't engage in the posterior position, although sometimes that's okay. To help make room for the baby, we're going to start with some daily exercises that you can choose to use to help make more flexibility and length in the muscles and the tendons and the ligaments from your feet all the way up your legs and into your pelvis so that your sacrum has more fluidity and mobility. The first exercise we're going to do is called the calf stretch. We just use a rolled mat or a rolled towel, anything you can find, step next to it, put the ball of your foot onto your mat and your heel square on the floor. Make your hips equal and put a little pressure onto that foot. First, you can bend your knee, hold your knee slightly bent, and feel that stretch. You'll feel that lengthening of the hamstring in the back of your leg. Once you've done one foot, step to the other side of your roll, put the ball of your other foot onto the roll, stand next to it, do a little stretch with a little bend. That does one set of muscles, and when you straighten out and lean a little forward, it does another set. Be gentle with yourself and listen to your body so that you're moving with your body to start gently. When you're done with that second foot, come to the center of your roll and put both feet, the balls of both feet onto your roll, your heels plant it on the floor behind the roll, and then bend your knees a little bit. Put a little weight on the roll. You'll feel a little stretch in the back of your ankles. And then straighten up and lean a little bit forward. We're going to do this with your partners the first few times so that you get the hang of it and you have your partner to hang on to. You know, because in pregnancy you want to be careful with exercises because your center of balance is a little different than you're used to. The lunge is a very important exercise to lengthen the muscles down the front of your pelvis, including the great psoas pair that influences your baby's rotation and descent during labor. Take a nice wide stance with one foot in front of you and one foot behind you. And then you're going to be bending your front knee, letting your back heel rise, and come down so your knee never goes in front of your toes. That's perfect. Your back is lovely and straight. And then you just come down a bit. If you can come down more, your foot in the back can go further. That's right, and your hips are lined up. And you just come into this bend, give a nice breath, let everything relax, your jaw relaxes and comes down just a bit. There you are, beautiful. And then come up for 2 seconds. That's it. And as you come down, take a nice breath. Relax any tense places. Feel your pelvis balanced. You're getting a nice stretch in your back leg. There you go. And then come back up. Let's switch legs. That's it. Do you feel a difference on one side already? Yeah, and bring this foot forward and that one back. That's great. Do you notice how this foot needs to turn? That tells us a story about your pelvis on that side. So find the comfortable place where it can be somewhat straight. There you go. And come down for 2 seconds. Take a breath. And then back up. So the 2 seconds is a guideline, you know, and you're just coming down. Your knee is bending without going in front of your toe. So it could come out to here if you felt comfortable doing that. And in a short time, you'll be able to lunge a little bit more with a little bit more of your pelvis in line with itself. It's easy to do on one side, a little tight on this side. It shows us about balance. You know, you could do this with Paul. So pick a foot to come forward and another foot to come back. And you feel that difference? Now you can help line up your hips very nice. Your back is coming into the stretch, your heels lifted, your back is nice and straight. Perfect placement of your knee. Nice breath, and then you kind of come up a little bit. That gives you some more circulation, and it also talks to your muscles about how you want to stretch. Beautiful job. You keep doing that. Try the other leg again. Let's do the squat. That's another thing to practice every day. You can hold on to each other by your wrist. This gives you nice stability. And now you're going to sit down in a chair. So your bottom swings back and your knees stay in front of your ankles. Here's your ankles. Your knee can come to my hand as you swing back. There you go. Paul's got you. Oh, you can go deep. You can let this curve happen and let your bottom swing out. So if you can't come down this low without your tail tucking in, then you don't need to go that low right away. So that's a beautiful curve there. And then you can come up. Oh, beautiful breath. And then go down again once you've taken a breath. It's nice to keep the squat in movement. Lovely full breaths, Ayana. There's a wonderful way to relax this broad ligament and bring more balance to the part of the body above the pelvis. Every part of the world, every region, midwives have devised ways to jiggle mothers. This helps loosen the structures into relaxation. It loosens the involuntary muscles. The Yucatan midwives devised a way that we can do this together in pregnancy. We're going to relax that broad ligament that's attached to the sacrum. Michelle, all you have to do is get on your hands and knees, kneeling here and resting over the ball.
So just like this.
Yeah, and then just cuddle up with the pillow, put your cheek here, and show the class how comfortable you are. There you are. Wonderful. Now let's have your knees under your hips. So bring your knees back away from the ball a little bit more. There we go. First, we're going to make a hammock for the baby. Michelle, can you help me to put this under your tummy? This hammock for the baby is a substitute to the broad ligament. Now, Michelle, I'm going to stand real close to your hips. And you can take a nice breath and relax your belly. That's it. This is placed evenly over the baby. I'm going to lift the weight of the baby towards Michelle's spine, but I'm not cramping the baby. I'm just supporting what the broad ligament would support. And then I check in with Michelle. How is that?
Good.
Now I'm going to begin the sifting. Gently at first, just rocking. I think of the rods on the choo-choo train and the engine that make little circles. How's that feel, Michelle? And I do it slow. Now see how my knees are bent and my back is straight, because I want to do this more than once. And then I check in again. How is this for you? Remember when we were talking about the round ligament spasms in front? Are you having any of those recently? Okay, when we have round ligament spasms, we don't go any faster than this. We lift and we make a gentle sifting motion. And I think of the choo-choo train, because that's the only way I can have a rhythm. Then when I stop, Steve, I'm going to slow down, gently slowing down and letting the weight of the baby back onto Michelle's spine. Would you like to give it a try?
Sure.
So let's take the rebozo in that part of your hand. It's as if you're clapping. And then you step pretty close. You can just barely bend your knees. You don't have to bend much. There you go. And lift the weight. And then, Michelle, you tell Steve how much weight you like lifted. And then you can just start gently lifting and sifting so that you're bringing her belly with you. Even coming up. There you go. And so let's make it a little easier, because we don't have to make it big movements. We'll make it little movements. See how I'm bringing the belly right with her? There. The sifting relaxes the involuntary muscles that are laced into the broad ligament. It relaxes what Michelle can't relax consciously. So this is a nice technique to do at least weekly. Well, the Yucatan midwives did it every 15 days. They started with the massage and then a rebozo sifting. There's 101, maybe 1,001 ways to use the rebozo to bring comfort and balance to pregnant women. This is one technique that's nice in late pregnancy because the mother can be on her hands and knees. Let's talk about this uterosacral ligament in the back that's attached to your sacrum, and give that a stretch with the forward leaning inversion. One of these every day will help make more balance in the lower uterine segment. The forward leaning inversion is important for every woman in pregnancy to do once a day. The women that should not do it are, you wouldn't want to do it with heartburn because it wouldn't feel good. So wait till you're before a meal to try it. But it's very important that women with high blood pressure don't do this. Women that are at risk of a stroke. Women that have so much water that the doctor is saying, come in every week and let's monitor you and the baby and watch how much this water is, see if we have to induce, and all those worries about polyhydramnios. A mother whose baby is switching positions almost every day. Maybe she's a 6-time mother. She has a lot of water and her baby's head down breech, head down breech. This might be a good exercise for her, but she should be monitored by a professional body worker to tell if it is or not. I wouldn't recommend it without her consulting a provider, an experienced qualified provider. So your baby's head down, and this is a fine thing for you to do, and I recommend it daily. Do you have any of those risk factors right now?
No.
No, that's great. It is also good for the mother with the breech baby, but it's good for both because it's not about flipping the baby, it's about making length of the uterosacral ligament and taking the twist out of the lower uterus. It's good for babies that are transverse, breech, oblique, or head down. She tucks her chin, she does a posterior tilt of her hips, and brings her lower back flat. In this case, it's a good idea. Sitting, it's not, but in the inversion, it's a good idea. 3 gentle breaths, letting her abdomen relax. See how close her knees are? So her bottom's up. Don't lay on your thighs. That's not correct. The thighs are free and lifted. Now, Amber, can you help her shoulders up? Just scoop under her shoulder.
Sure.
Push up off the floor and sit down on your heels. There you go. How did that go?
Good.
Did you get a pounding in your head?
No.
Oh, good. Good. So I think that 1 inversion a day keeps the cesarean away. We'll see. We'll see. But the goal is to make more room in the lower uterus. That's what we're going for. This technique was brought to us by Dr. Carol Phillips, a chiropractor now in Annapolis, when she observed a birth in which the mother went upside down after a long labor and the baby came out. And Dr. Phillips said, "Why did that happen?" And she put 2 and 2 together with the uterosacral ligament. And it's been helping many women. Okay, there's not a magic technique for all women, but this is one that's very important. It helps many women. So now I want to address the pelvic floor. How do we know if there's a pelvic floor problem? There's often discomfort in pregnancy, discomfort in the back, the hip, digestive, any problems with constipation or diarrhea, even heartburn. If you're having discomfort, we want to pay attention to the pelvic floor. We want to pay attention to the psoas. Michelle and Steve are going to help us learn the sideline release. And we're going to use the massage table to start out with it. But you can also use the couch in your own home. Michelle, your head is going to go here, and you're going to face Steve. Steve's going to be in the middle. Let's get the pillow out from under your shoulders. Michelle's shoulders are stacked. This shoulder directly above her lower shoulder, the top hip directly above her lower hip. This is very important to keep the torso straight. Her head is straight. The pillow doesn't lift her head up or let it hang. Now, right now, she stays on the edge of the table until Steve supports her hip. So Steve, let's start with one hand right on the crest of her hip and the other hand on top of that one. And you're going to stabilize her when she does the technique. Here's the starting position. Your lower leg, Michelle, is going to be straight as an arrow. Let's take a look. This leg is straight as an arrow. This foot comes up and is flexed. Now, your top leg is the leg of the action. We have 36 muscles going to the pelvis, and we're going to deal with half of them. So 18 muscles are going to get a stretch. Steve keeps her hip straight above. So is she in contact with you? Now they're tummy to tummy because Steve's at a diagonal to let there be room for the thigh. The shoulders are still stacked. The head is still straight. She's got her hand on her arm. Okay, her toe comes up. Now this leg lifts up enough for her thigh to clear her other thigh, and then she just gently drops her leg off the end of the table, lets the muscles here be nice and loose, very soft. How's that feel?
It feels amazing.
She's liking it. So see, she has no twist here. Now, Steve's job is to keep that top hip directly above the other hip, but he has a challenge. He can't see over with any kind of accuracy, but I can see from the side. He's doing a great job. He's got her straight. Steve's supporting Michelle. so she doesn't lean forward and twist her torso, which would make this exercise pointless, or actually maybe pull a muscle in her mid-back, which would be annoying. So he's got his hand in front of that iliac crest, and then he's holding it down and doing a slight amount of downward pressure. That downward pressure is just enough to move the pelvis a slight bit. Very easy to do in pregnancy with the loose ligaments. What the downward pressure does is loosens the attached muscles to the inside of the pelvis so they're loose, while the outside muscles in the piriformis and the deep six, the rotators, are getting a nice pull from the weight of her leg hanging off the edge. Not everybody has a massage table. Most people have a couch or the edge of a bed if it's firm enough. So partners can learn how to do it and then do it at home on the furniture that you have. Now this couch is lower, so shorter women will have an easier time. Sometimes if your leg is touching the ground, you're going to have to find a higher surface. It's very important with the sideline release that we do both sides. If we loosen up one half of the pelvis and leave the other side tight, the baby's going to come down kittywampus. In fact, we have a lot of babies coming down kittywampus right now because of our habits of crossing our legs and driving using our right leg a lot. That makes these muscles in our right side shorter. So we don't just let the right leg hang, though, because muscles work in partnerships. We have to get both sides. Now, what I see here is that Joanne got into position without putting her lower hip up to Steve. So let's try again. Lift this leg. Bring your hip into contact with Steve. Steve, be careful of the bump on the table. You might have to go that way. Now, turn the other way. So tummy to tummy. So you're going to turn and face Joanne with your leg in a place on the table that she can snuggle up to. There she goes. This leg is straight as an arrow, her foot flexed. This leg rises, clears her thigh, and then lets go. And she doesn't need me to do it for her. I'm just talking her through it. This toe comes up. It's sometimes hard to get this toe up, so don't make it a priority. The most priority is to let this leg hang. We need to repeat this. We'll do this once a week as long as you've got a helper. Let's push her hip back a little. There, she's straight. Let's see how we're doing here on the couch. So this shoulder is a little forward. Let's bring it back and keep your hips stacked. We have to make sure the pillow is not under the shoulder. That's lovely. Now her back is straight. Amber's just put her hand in the back to test it, and then she hangs on. Can you press down on the couch without sinking her into the couch? Yep. Very nice. Tummy to tummy, Amber's at a diagonal. Because the couch is low to the floor, she's kneeling. How's that feel?
Feels really good.
She's liking it. That's great. And then we can see her leg. How long do we do this? We might notice in pregnancy that her leg lengthens, and that means it's released. Then she can do the other side. There's one more technique I'd really like to share with you. It's a nice foursome. If we do rebozo, and then forward leaning inversion, then sideline release, we would end with standing sacral release. We can do them in any order, but this is a nice way to do it. The standing sacral release helps bring mobility to the sacrum. The sacrum is the base of the spine, and it really is involved with the health of the spine all the way up to the neck and even into the skull. So if we have more mobility in the sacrum, we can get benefits like more comfort in our pelvic area. We can get more comfort in our respiratory diaphragm, including helping us over heartburn, including helping us over snoring. That happens with some people as a benefit. I don't know of any reason not to do a standing sacral release except for the mother's desire. The amount of pressure that we use with the sacral release is so light, it's like holding a balloon without dropping the balloon. If you put your hand out and imagine putting a nickel in your hand, the weight of the nickel is the amount of touch that we use to do the standing sacral release. Sarah, will you come up and try the standing sacral release with us? Thank you. Now, have you done this before?
Yes,
Yeah,
I have. It feels
awesome.
really good. It's hard to
Okay.
get out of your mind, though. You have to really
Yeah,
relax
and
into it.
as a yoga teacher, I think Sarah can kind of go into her own place. So one of the things that my hands are doing, even though the touch is so light, is the fascia is so sensitive that the fascia feels that light compression. It is compression, but it's super light. And if I push any further, I start talking to the muscle, and the fascia says, well, you're talking too loud. You're not talking to me. You got to whisper. So we're going to whisper. And just letting your belly be soft and go into the movement of your sacrum. You feel that pulse. Sometimes you feel the craniosacral pulse of the body in some women, some you don't. And sometimes what you feel, I talked about the tapping, what I'm feeling with Sarah feels like larger areas of movement, but not deep like the muscles, but on the surface. So when I feel it release, then I might move to another place that's a little tight and start again. When the pelvis area gets released, sometimes women will feel quite loose in the pelvis, but they'll start to feel a little tight in the chest, in the respiratory diaphragm. So then I'll just move up to the new place. And we would just take whatever time she needed. So again, it's wonderful after a long car ride. It's wonderful to do once a week. Now, if I weren't here and Sarah wanted to do it and her partner wasn't here, she could also do some things to release her own sacrum. So when we get used to movement, we start to crave that feeling of freedom in our joints and our bodies. Yoga keeps her body in motion. Exercise, stretching, belly dancing, all these things keep the fascia loose, swimming. And so if we have repetitive movements, we need to do some stretching in other directions to make up for the habitual repetition. So give it a try. It looks a little odd, but it feels a little good. Huh? How's it feel, Sarah?
It was amazing.
There are many ways of moving our bodies and getting into balance. We've gone through a few today. We've talked about referral to body workers. You might have some favorites, some things you like to do. One we don't do in class is walking. Walking 1 to 3 miles a day is really vital to get that rhythm of movement into these muscles to the pelvis so that they can restore themselves after hours of sitting or standing. Find a safe place to walk. Try to walk without a treadmill if you can, and keep mobile. Now that you've begun to achieve some balance, we're going to talk about maternal positioning, because before we do balance, maternal positioning is not as effective. But with room for the baby, then the mother's postures and positions that she rests and moves in will help the baby move to the front of her uterus and maybe to the left side. So let's play the flashlight game. This little light that you have growing in your belly, imagine that there's a beam of light that comes out from your navel so that we can see your position. This is going to be your guide. Where is your light beam going? That's your guide to your posture and in rest and movement. Okay. We want your flashlight beam to be equal or to gradually go down. Okay. And let's have your knees apart and let your belly be a hammock for your baby. This means that you're sitting on the front of your tuberosities. Okay. That will help your baby move to the front, because what it really does, it's not so much about your position. Your belly isn't a water balloon, equal on all sides, where if you lay on your right, the baby goes to the right. You lay on your left, the baby goes to the left. This is unusual. It maybe with 6 babies and a loose tummy and a lot of water, that can happen to an occasional woman. But for most of us, changing our position doesn't change the baby's position. We need to make room for the baby so that gravity begins to help, right? Remember our bell curve. So sitting on the front of your tuberosities helps your muscles be longer. Let me show you what I mean. Can you lean back on the couch? Sure. Now your flashlight's going up.
Right.
So not only is your back lower than your belly to make a bed for your baby on your spine. This is said to encourage the baby to be in a posterior position. But what it's also doing is putting your weight on your sacrum and reducing the mobility of your sacrum and tightening the ligaments to your sacrum. It's all about sacral movement and balance in the pelvis. That's more important. But to achieve that, we do the balancing and we do maternal positioning both. So let's bring you up to the front of your tuberosities, letting your belly be a hammock, and then your flashlight's going towards the floor. It doesn't have to go extremely towards the floor, but anything towards the floor is helpful. Or if you stand up, it goes neutral. See? So neutral or down is what we're aiming for. You can look around your house and see where your posture traps and eliminate them. If you would sit on the bolster, now if you sit in your usual way that we sit in America, you're going to be sitting on your sacrum. So let's come to the front of your tuberosities, letting your knees come down. And then you're letting your back have a curve and your hips come out behind you. Now you're making these muscles in the front of your pelvis be open and long. And this is the desirable position for all women in pregnancy, but it's more effective with increased balance. And in fact, this is one of the things you do to get that balance. Okay, now how about a birth ball? And you can see as her knees are a little bit more apart, make a tripod and let your back come in. Okay, let's bring your hips back. There you go. Yeah, because you want your hips to come out this way. This part of your back has a gentle curve. There, and then you can draw your shoulders apart. There, and down. Beautiful. With a chair, you can sit on an inflated disc so that you're not on a hard surface. This gives that mobility to the spine. And yet these discs are difficult to find and they're quite expensive. So I have an inexpensive solution. We can use an exercise ball such as a slow-mo or a children's ball such as a Gertie ball. And these are available at children's toy stores or at Amazon. We use the ball in a vertical direction, pretty much deflated. So your tuberosities go on either side of the ball, and you sit on the front of your tuberosities. Let's give that a try. Is that easier to sit on the ball?
Yeah.
Yeah, that's nice.
Feels really comfortable.
Yeah. You just take the plug out, let the air, what seems like letting the air out, right? And then it's ready to go. This can also be used in a car. You can put this ball in between your sits bones in the car to help your spine have dynamic movement, but to maintain the safety of the bucket seat of the automobile so that if you have to have a sudden stop, you don't go into the steering wheel, right? So we wouldn't put a pillow on the car. We would use a ball like this, because then you're in contact with the seat, but your tailbone is not in contact with the seat. Pick positions to sit where your tailbone is not in contact with your chair. You can change the amount of air in it to have comfort. If you have a nice dance song in the car. You can put a little more air in it and move around a little bit. That motion of the spine, gentle motion of the spine, keeps it lubricated, keeps it flexible, keeps your muscles healthy and happy. Let's see where your flashlight is when you're laying directly on your side. That's a very neutral position. You see how the pillow is between your knees and between your ankles. So there's no twist in the torso. A twist in the torso can twist the uterus. So we want to take the twists out and lay down symmetrically and evenly in our bodies. If you were to turn your flashlight closer to the couch, what position would you pick? Let me take your flashlight for a minute.
If I straighten my bottom leg.
Okay, you've got your bottom leg straight and behind you, your top leg in front of you. You can even do that with your bottom arm if you want. Leave it in front, or some people like to put it behind them when they're resting. Now where's your flashlight?
Yeah, it's
You would have to point it right down into the couch. That's great. So either of these are rest smart positions. Rest smart, move smart, using posture and your own dynamic motion to help make room for your baby and maintain room for your baby. All right, thank you, Joanne and Amber.
So in the rest smart positions, is it preferred to lay on your right side or your left side, or does it not really matter?
That's a really good question, because a lot of pregnant women are recommended to lay on their left side. And the idea is that blood pressure is usually better when women lay on their left side, but you don't have to exclusively lay on your left side unless your care provider specifically tells you that in an emergency situation. But as you're sleeping in bed, of course, you'll turn to your right side and your left side because of comfort. It's more important whether you're sitting forward compared to back. Let me show you what I mean. Here we have two mothers' torsos, right? And this one's sitting on her sacrum, and this one's sitting with her knees lower than her hips. And we see the little light of the flashlight coming from these mothers' little lights. This one's going down, this one's going up. Let's see the effect inside, shall we? When the mother has good posture, the idea is that her baby's back is going to come to the front. Sitting on our sacrum shortens the muscles, destabilizes the pelvis, also puts gravity in the back. Gravity works 24/7. And we have the baby who's settled with the back to the mother's back. Some women will have good posture during their pregnancy, and their baby remains in this posterior position. Why does that happen when they've been so good about sitting up and sitting forward? It's because the imbalance has been there since before pregnancy in a stubborn little spot, and we have to find that. So we're going to go from the top of the womb to the bottom of the pelvis, exercising and releasing, and sometimes getting referrals for body workers, such as physical therapists, chiropractors, myofascial massage, craniosacral therapists, and Maya massage. Maya abdominal massage is quite different from pregnancy relaxation massage. Referral to a body worker is very important. Moxibustion, acupuncture, herbology, and homeopathy are other options. I expect all of your labors to go well. You're doing the balancing, you're mobile, you're moving. But if there was a situation where your labor seemed prolonged, or your pregnancy seemed prolonged and you're facing induction, your water broke and there wasn't contractions, you had back labor, or it seemed like the labor just was strong but not progressing, that's the time to do the Fantastic Four. We start with the rebozo, in between contractions and labor. Then we do the inversion through 3 contractions in labor. You really need support in the face to do 3 contractions of the inversion. Then sideline release on the edge of the bed or couch, again, through 3 contractions on each side, okay? So you're not going to be pulling these out unless you need them. The 4th one is a standing sacral release, which you can do between and in contractions. And those 4 together open up so many possibilities for your labor to progress. They're fantastic. That's why they're the Fantastic Four. Give them a try if you need them. Remember them.